Welcome back to the deep dive. Today we're cracking open chapter 49 of Focus on Nursing Pharmacology. We're looking at the drugs used to treat anemias.
Which is some really dense material.
It really is. But our mission here is simple. We want to give you a genuine shortcut. We're going to zoom in on how blood is made, look at the three main types of anemia, and then really distill the four big drug categories.
And hopefully you'll walk away knowing the most critical safety points for each one.
Exactly.
Okay, so let's unpack this. The whole foundation here is that, life depends on red blood cells, RBCs, to carry oxygen. Anemia is when that system breaks down.
Either you don't have enough RBCs or the ones you do have just aren't working right.
So before we even get to the drugs, we have to talk about the manufacturing process, like a biological shopping list.
That process is called erythropoiesis, and it happens in the bone marrow. To build a good, healthy red blood cell, you need a few key ingredients. First up is iron.
Absolutely essential. That's the core of the hemoglobin ring where oxygen actually binds.
Then you need your basic building blocks, amino acids and carbohydrates. And third, and this is so important, you need vitamin B12 and folic acid.
Those are for the structure, right? The stroma. They make the cell tough enough to survive in circulation for, 120 days?
That's the one. And this whole production line is very tightly controlled.
Yeah, and what's fascinating here is that the controller is erythropoietin. It's a glycoprotein, and it's made mostly by the kidneys.
So the kidneys are basically sensing oxygen levels.
Exactly. If they sense low oxygen or just decreased blood flow, they send out the signal, the erythropoietin, to the bone marrow, telling it to ramp up production. When that balance is off, that's where we get into these deficiency anemias.
And the most common one is iron deficiency anemia.
By far.
It's surprisingly easy to get there because even though we're great at recycling iron, we still lose a little bit every day.
And that gets worse in situations with high demand, like menstruation, pregnancy, a growth spurt in kids.
But the really concerning cause is that slow, chronic GI bleed, maybe from long-term NSAID use or something else that's gone unnoticed.
And without enough iron, your cells end up pale and small. They just can't do their job.
Okay, so then you have the anemias that mess with the cell structure itself. Megaloblastic anemia.
Right, this one is all about a lack of vitamin B12 and or folic acid. Without them, the cell's DNA synthesis just slows right down.
And you end up with these huge immature red blood cells called megaloblasts, and they die off way too early.
But here's where it gets really interesting. Let's dive into a specific type of that called pernicious anemia.
Ah, the classic case. This isn't just about not eating enough B12, is it?
Not at all. It's a plumbing problem.
A plumbing problem. I like that.
Yeah, pernicious anemias is caused by the lack of intrinsic factor. It's a substance made by your gastric cells. Without it, you could swallow all the B12 in the world, and you just cannot absorb it.
And B12 isn't just for red blood cells. That's the other crucial piece.
Right. It's also critical for the myelin sheath in the central nervous system. So a deficiency there leads to, numbness, tingling, poor coordination, real CNS effects.
So we've talked about anemias from a lack of parts, but what about when the body makes a part that's just fundamentally wrong? That brings us to the genetic side of things.
Sickle cell anemia.
Exactly.
Yeah, sickle cell is a chronic hemolytic anemia. That means the red blood cells get destroyed way too early. It's all because of an abnormal hemoglobin called hemoglobin S.
And under stress, like low oxygen, the cells warp into that sickle shape.
And those cells are rigid. They get stuck, they clog up small blood vessels, and that leads to tissue death and that awful severe pain of a sickle cell crisis.
Okay, let's pivot to the drugs. How do we fix these problems? Starting with the big guns, erythropoiesis-Stimulating Agents, or ESAs.
Your epoetin alfa, your darbepoetin alfa.
These drugs basically mimic that natural erythropoietin signal from the kidney. They tell the bone marrow, hey, ramp up production now.
And they're mainly for anemia from kidney failure, certain AIDS therapies, or some cancer chemotherapies. Darbepoetin is a bit more convenient since it's once-a-week dosing.
But this raises a huge question. We're artificially boosting production. What happens if we make too many red blood cells?
That is the multi-million-dollar question, and the answer is why these drugs have serious black box warnings.
How serious are we talking?
Critically serious. If you remember one thing about ESAs, it's this number. The target hemoglobin must be no more than 11 GDL. Full stop.
And why that specific number?
Because studies show that pushing it any higher leads to a major increase in the risk of death, heart attack, stroke, DVT, and in cancer patients, It can actually speed up tumor progression.
Wow. So it's a terrifying tightrope to walk. You need constant monitoring.
Absolutely. And that makes sense, right? You're making the blood thicker, more viscous, so of course the risk of clotting goes up.
Which is also why they're contraindicated if you have uncontrolled hypertension. You're just adding more pressure to an already stressed out system.
Yep. Oh, and another key point for hemodialysis patients, the recommendation is to give it intravenously, not subcutaneously.
Why is that?
There was a finding of something called pure red cell aplasia. Basically, the bone marrow stops making red cells, and it was linked to antibodies forming when it was given the subcutaneous route.
Got it. Okay, moving on to our next class. Iron preparations. The prototype here is ferrous sulfate.
This one is pretty straightforward. You're just giving the body the iron it needs to make hemoglobin.
But iron itself can be really dangerous.
Oh, extremely. It's toxic, especially to neurons. An overdose can cause CNS toxicity, coma, even death. That's why we have an antidote.
Deficiency agents.
Exactly, like deferoxaminoxylate. They literally claw the excess metal out of the body so it can be excreted.
And for patients taking it orally, what do they need to know?
Well, GI upset is really common: nausea, constipation. But the crucial teaching point is about their stool. You have to warn them that it's going to turn dark, tarry, or even green.
So they don't panic and think it's a GI bleed.
Precisely.
Mm-hmm.
And the other enemy of oral iron is, well, almost everything. Absorption goes way down if you take it with antacids, tetracyclines, or even just eggs, milk, coffee, or tea.
So you've got to space those out by at least a couple of hours.
You have to. And if someone just can't absorb it orally, then we have to go parenteral with something like iron dextrin.
And that requires that special injection technique, the Z-track method.
Yeah, you literally pull the skin to one side before you inject. Then when you pull the needle out and let go of the skin, the track is broken. It traps the medicine deep in the muscle.
And that prevents it from leaking out and staining the skin. But you have to warn them that injection can be painful.
For sure.
Okay, let's circle back to the megaloblastic anemias. First, folic acid.
Super essential for any rapidly growing tissues. That's why it's in every prenatal vitamin. It's absolutely critical for preventing neural tube defects in a fetus.
And treatment is just straightforward replacement therapy.
Yep. Same idea for vitamin B12, which we know is for RBCs and that myelin sheath. But for patients with pernicious anemia, the route is everything.
Because they lack that intrinsic factor.
Right. So oral B12 is useless. It has to be parenteral or intranasal. Usually it's an intramuscular shot of hydroxocobalamin. You start daily, then taper to monthly for life.
And there's a nasal spray option too.
There is sickle-shaped. It's a convenient weekly alternative for adults. But the bottom line is, if absorption is the problem, parenteral B12 is mandatory.
Okay, finally, our last category, the treatment for sickle cell anemia, which is hydroxyurea.
This is kind of ironic, isn't it? It's a cytotoxic drug, something we use for cancer.
But here we're repurposing it. How does it work?
It actually increases the amount of fetal hemoglobin in the blood. And that fetal hemoglobin essentially dilutes the abnormal hemoglobin S.
So by watering down the bad stuff, you get less sickling, less clogging, and fewer of those painful crises.
That's the goal. But since it is a cytotoxic agent, you have to monitor for some serious adverse effects. Bone marrow suppression, GI issues, even a higher risk of other cancers down the line.
Let's wrap up with some really crucial lifespan considerations. For children and iron, 2 huge points.
Oh yes. First, if they're taking liquid iron, it has to be through a straw. It will stain their teeth.
And number 2,
Iron is acutely toxic to children. The supplements have to be kept locked away, out of reach. It's a major poisoning risk.
good. And what about for diagnosis? I saw a fascinating point in the source about racial variations.
Yeah, this is really important. Hemoglobin and hematocrit levels in African Americans tend to run about 1 gram lower than in other groups.
So you have to adjust your diagnostic norms, otherwise you might misdiagnose anemia.
You have to. It's a critical piece of the assessment puzzle.
So if we boil it all down for our listeners, what are the 3 most critical takeaways?
Okay, number 1. With ESAs, you monitor hemoglobin like a hawk, and you never ever let it go above 11 GDL.
Number 2, with iron, you educate on the toxicity risk and on avoiding all those things that block absorption: eggs, milk, coffee, tea.
Number 3, for B12 deficiency, you have to confirm the why. Is intrinsic factor missing? Because that answer decides your entire treatment plan. Parenteral versus oral.
Perfect. So we've covered the 4 pillars: stimulating production with ESAs, replacing iron, replacing B12 and folic acid, and then altering hemoglobin for sickle cell.
That's the whole story.
So what does this all mean for the future? We focused on replacing things today, but think about something like a plastic anemia where the whole bone marrow just fails.
Pancytopenia, a devastating condition.
Right, but there's a newer oral drug, L-trombopag, that's now approved for it. It's a thrombopoietin receptor agonist. It actually reactivates the failed bone marrow.
So it's not replacing the cells, it's telling the body to start making them again.
Exactly. Which really makes you wonder, are we getting to an era where we stop replacing what's missing and we just learn how to flip the body's own internal O&N switch for blood production?
A fascinating thought. A true evolution in pharmacology.
A perfect place to leave it. Thank you so much for joining us on this deep dive. We really hope this gave you the clear, actionable shortcut you were looking for. Keep learning, and we'll catch you in the next one.